Hello, everybody, and thank you for joining us here at MAG, Medicolegal Assessments Group, for another one of our Meet the Specialist sessions. These have been going an absolute treat, and I see on our YouTube channel that they're getting lots of watches and more people joining to watch them. So thank you so much for registering and making the time to join us. Today's specialist is very, very, very interesting. We have Dr. Andrew Gall, who is an anatomical pathologist. So his work is quite specific and niche, but is in fact really, really critical in the IME space. So without further ado, I will hand over to him to give a little bit of an introduction, a little bit of a blurb about what he does. At the end of the session, there'll be the opportunity to ask questions if you have any. And thank you so much. Over to you, Doctor.
Thanks, Michelle. Look, I was born in Hungary, came to Australia at the age of 10. I did my high school education here. I went through medicine at Sydney University and subsequently trained as a specialist pathologist at St Vincent's Hospital in Sydney. Now, pathology is defined as the study of the nature and the causes of disease, and it underpins all aspects of medicine. Classically, it has been divided into 4 separate areas, and now there's a 5th one. So most people, I think, when they think of pathology, they think of blood, and that is covered under hematology, and I don't do any of that. It's a specialized area. Then the other division is biochemistry, so that looks at various chemicals in the blood and looks at how kidneys, liver functions, whether you had a heart attack or chest pain is due to overexertion. That's biochemistry. Microbiology deals with infectious disease, so we culture bacteria, viruses, fungi, and that sort of stuff. So I don't do any of that. My specialty is anatomical pathology, which is the study of tissues, human tissues and cells. So a major part of that is the diagnosis and classification of tumors, whether they are benign or malignant, and if they're malignant, what type of tumors, because all this has an enormous influence on the treatment of those tumors, and also has some medico-legal aspects that I'll go into a bit later. The other aspect of anatomical pathology is the study of disease of various organs, such as skin, kidney, liver, and if you have it's suspected that you've got a liver disease, they might take a small sample of the liver, and in anatomical pathology, we can tell the clinicians as to what's wrong with the liver, and treatment can start from there. Now, it's very important to realize that in anatomical pathology, it's a snapshot in time, and it's a topographical disease, especially in tumor pathology. In other words, if one looks at blood and we take a sample of, say, 10 milliliters, that sample is representative of the rest of the 5 liters of blood that's circulating in the body. With anatomical pathology, it's vital to know where the tissue comes from, because you can only make a diagnosis on what we see. So if the biopsy is wrong, then the result will be wrong. What else? Now, one of the things to understand about our specialty is the absence of malignancy in a biopsy. Does not mean absence of malignancy in the patient. It merely means that a bit of tissue that was submitted for pathology but didn't have any tumor in it. Now, my medico-legal work is divided into 3 main areas. The major part of what I do is making diagnoses related to claims arising from previous asbestos exposure. And there are 3 main diseases that are linked to asbestos exposure. One is mesothelioma, which is a malignancy of the covering of the pleura, and that's, everyone hears about it, the newspapers write about it. And these come with large compensation claims. And on occasion, the diagnosis is incorrect. Clinicians tend to think, look, someone comes, they've got a tumor, patient's got a tumor, they worked in the asbestos factory, therefore you put 2 and 2 together, you come up with 4, you must have mesothelioma. And of course, that's not correct, because people who've been exposed to mesothelioma will be subject to all the other diseases that everyone else is subject to. So in other words, you can have mesothelioma and have a kidney cancer, or you can have an ingrown toenail. It doesn't mean it's related to the asbestos exposure. Now, the second disease that's associated with asbestos exposure is what's called asbestosis, which is a fibrosis of the lung, so as a result of inhaled asbestos fibers. So there are 2 requirements there. One is that asbestos fibers should be present in the lung in sufficient quantity. And the second one is that the fibrosis, or the reaction of the lung forming this fibrous tissue, which is not impermeable to oxygen, should be related to the asbestos fibers. And once again, clinically, clinicians again say person's got a fibrosis of the lung, they've been exposed to asbestos, therefore the 2 are causally related. But of course, that's not always the case, and not infrequently, if I get a lung biopsy, which was diagnosed as asbestosis, I may find that there are no asbestos bodies in there. The patient's got fibrosis. Fibrosis can be caused by lots of different insults to the lung, and not necessarily related to the fact that they've been exposed to asbestos. And the final disease that's linked to asbestos is lung cancer. And again, there are certain criteria whereby one should attribute that lung cancer to the fact that the patient has been exposed to asbestos, because lung cancer is caused by lots of different things, including in particular smoking. So one gets a patient who's smoked, been exposed to asbestos, got lung cancer. The question then becomes, is the lung cancer causally related to the asbestos, in which case it can be compensated, but if it's not, well, then no compensation is payable. Other cases, so this is my asbestos work. Other cases that I deal with are delayed or misdiagnosis of cancer. So I had a case recently where a patient who lots of
It's all right, Doctor. I've managed to mute that.
Okay. So as I said, the other sort of cases that I deal with are the delayed or misdiagnosis of cancer. I had a patient recently who used to visit his dermatologist, had a little lump on the skin, which wasn't looked at, or it was looked at, nothing was done. It was biopsy was taken some years after it was first noticed, and to cut a long story short, the patient died of disseminated skin cancer, and there were lots of steps along the way where things went wrong. It's said that to kill a patient is quite difficult. Patients are very resistant to being killed, and it's like a Swiss cheese model of medicine that once all the holes in the Swiss cheese are aligned, so in other words, one mistake follows another mistake, patients fall through, and you get to the compensation area where I see them. And dealing with cancer diagnosis, well, the other problems are the mistaken diagnosis of cancer, and I've had a few recent cases of that. One concerned a woman who felt a lump in her breast. A small sample was taken through a needle, was diagnosed as cancer. It's a type of cancer that often occurs in both breasts, and as a result, both breasts were removed, but the initial diagnosis was incorrect, and in fact, there was no cancer in either breast. And another similar case was involved a stomach, where a little biopsy was taken through an endoscope, diagnosed as cancer, the stomach was removed. There was no cancer in the initial biopsy or in the subsequent stomach. And so I always advise my friends and relatives that if they get a diagnosis which involves serious consequences, loss of limb or body organ, always get a second opinion. Because most of the time the diagnosis is correct and they're wasting their time and money. But now and again, the diagnosis is incorrect, and it's always nice to get a second opinion. And the third and sort of most uncommon area where I've written reports are the claims arising from faulty medical devices, and we've had a series of these cases. The metal joint implants which wore away and caused metal deposits to be shorn off into the blood. So it's a case for that. Another case involved the use of cyanoacrylate surgical glue, and that caused a lot of problems. And again, both the metal and the surgical glue can be seen in tissue sections, and so the case revolved around that. Now, what I find interesting in my line of work in medical legal reports is how different it is when I write a surgical report to a referring surgeon. Report on a tumor to a colleague might take me 5-10 minutes, maybe half a page. Whereas if I write the same report for sorry, am I lost? If I write the same report for a solicitor, it might take several hours and many pages. So to finish off, I'm sorry, I've lost things somewhere there. Well, to finish off, there's an aphorism in pathology that the length of the report is inversely proportional to the certainty of diagnosis. Short reports mean pathologist is certain in diagnosis, long reports mean there's less certainty. So if I've any questions, happy to answer them.
Thank you so much, Dr. Gal. My apologies for having to pop off the screen for a moment. We had a visitor in our office today.
Yes.
And I had to go and contain him.
Okay.
That was really interesting. I certainly learned some stuff myself. And I had a quick question to ask of you. Is there ever an instance when you are given a sample of tissue to analyse because a biopsy has been done where the specialist believes that there is a particular type of tumour, cancer, something present? Do you ever go back to them and say, look, this tissue sample, it doesn't have that in it, but it doesn't look right. Could you get me another biopsy?
Well, that often happens in clinical practice. So yes, that happens because as I said before, we can only report on what we see. So we work together with clinicians, and they say, look, we suspect such and such, and I look at the tissue and they'll say, look, I can't see any evidence of such and such. We have a discussion, and perhaps a further tissue sample is taken. It not uncommonly occurs in skin cancer. There's initial sample taken, which is skin cancer. The patient is then sent to, this is done by a dermatologist. The patient is then sent to a surgeon who then cuts around that area of the biopsy, and I don't find any residual skin cancer. And the assumption is that the initial sample removed all of the skin cancer, and that's all there is. So everything needs to be taken in context in the correct interpretation, which at times may be difficult for lay people to understand.
Yeah, absolutely. Now, I have another question from somebody who was not able to attend, and they wanted to know that where something has been excised and sent for pathological examination, do you ever find that not all of it has been removed, that there's bits like you haven't got a total piece, and then you've got to go back and say to the specialist, you haven't removed all of this?
Well, that happens not infrequently. And so the problem in surgery is to remove all of the cancerous tissue, but try and remove as little of normal tissue as possible. It's always a difficult risk-benefit analysis. So the surgeon tries to assess during the operation where the cancer is, and sometimes they get it wrong, and we can tell them, look, there's still cancer left at this or that point, and then they go back. So this is not unusual, and it doesn't mean the surgeon is negligent. It's just part of the process.
Right. Well, thank you. That's actually also cleared up another question I had about possible negligence. Isaac or Michael, do either of you have a question you would like to ask of Dr. Gal? You can unmute yourself or raise your hand or type your question in the chat. No, that is awesome. Dr. Gal, thank you so much for your time today, giving us a little glimpse into the world of an anatomical pathologist. This has been indeed very interesting. I thank you so much, and thank you everyone else. Have a great rest of the day.
Thank you, it's been a pleasure.
Ta. Stop recording.